Morning, everyone, and I thank Hari and Dr. Pavan for this kind invitation. Always a pleasure being at BRONCHUS, and Dr. Ashutosh and the team for having us here today talking about lung cancer screening in India. So my talk here is about the Indian perspective, about the early detection of lung cancer in India. And I'll talk about it in three subheadings. Why do we need it? What are the problems, what are the roadblocks that we encounter as Indian pulmonologists when we try doing it, and what I think we can do about it to make things better for us. So when you look at the global data, when you look at lung cancer in general, the trend is that we tend to pick up lung cancer quite late. Even if you go by the international data, you would see at the time of diagnosis, globally, a majority of these patients would be picked up when they have, a significant burden of the disease, when they're already in stage 3, stage 4. But when you talk about India per se, the situation is really bad. Now, this is our work from the Metro Center of Respiratory Diseases Tertiary Care Center in North India. We were trying to look at when the patients of lung cancer, at what stage of their disease they come to a tertiary care pulmonary center in India. And at that time, what is their quality of life and how well are they doing? And this is what we wanted to do. So we had 87 patients over the period of 1 year. 93% of these patients presented to us with advanced lung cancer, stages 3B and above. 61.8 were actually stage 4 with distant metastasis. And we were looking at their quality of life scales, and these were the scales that we were using. These were from the EORTC. And we were, trying to see how different is the quality of life of Indian patients when they are picked up with lung cancer vis-a-vis their Western counterparts. So if you look at the EORTC group, and if you look at the Indian study group there, we were looking at their physical functioning, we were looking at their role functioning, their emotional functioning, their cognitive functioning, their social functioning. If you look at the comparison between the European population and the Indian population, there was a statistical significance. The difference between the outcomes, the overall quality of life, about whatever parameter you were looking at, whether it was their emotional function, their cognitive function, their role functions, all of it was significantly lesser than their Western counterparts at the time of diagnosis. So yes, we do need screening because majority of our patients, they come to us when they're already very sick and we really cannot do anything about them except palliation. And also because at the time of diagnosis, the quality of life of these patients is already extremely poor to begin with. And when you start treating them at times, you actually make things worse. There are certain unique set of challenges that Indian Asian physicians have to face when you're trying to screen patients for lung cancer in our country. So the average age of lung cancer in India, in Asia, is actually much lesser than what we probably see in the Western countries. All of us as pulmonologists would agree, we see patients as young as early 30s presenting to us, especially female patients presenting to us with various forms of lung cancers, especially adenocarcinomas. Many of these patients are non-smokers, and there are a lot of endemic risk factors which are prevalent in our country, which would include air pollution, volatile cooking oils, tuberculosis, and all these recurrent chest infections. The AQI levels, the ambient air pollution levels are extremely high in a lot of parts of our country. So, when you're trying to actually screen these patients, there are a lot of differences between the classification criteria which have been used in the Western population and whether, because of our unique, the characteristics or the unique problems that we have in our patients, whether we would be able to adapt the Western guidelines to our practice. So, are we really sure that the Western risk factor calculators are they really applicable for our patients? Indian patients, the baseline lung x-rays, the baseline, because of the high prevalence of tuberculosis, respiratory infections, repeated respiratory infections, we do see a high volume of scarred lungs. And to pick up a nodule probably in them, and even if you do, you probably, at times you don't know how to proceed with those patients. So just picking up a nodule in an Indian context could mean a lot of things apart from lung cancer. The resources for checking for screening are not available universally in our country. Advanced IP PET CTs, there is obviously limited availability, so every patient might not have access to these facilities. And even if you do, even if you've screened a patient and you've found out a nodule, try searching for a thoracic surgeon who can do something for these patients, especially if you're working in a government setup. I work in one of the largest hospitals in the country, and even for us at our center, getting a surgeon, getting a thoracic surgeon operating on a small nodule is not easy. When you talk about PET CTs, when you talk about, this is Indian data, when you talk about CTs and PET CTs for solitary pulmonary nodules, there's this over-reliance to say somehow, a lot of patients, we know as per the NCCN guidelines, we are supposed to do tissue diagnosis for patients who do come up with some kind of a lung nodule. And in our country, probably, there's this over-reliance on PET CTs. And this is a retrospective study from India wherein they have looked at SPNs and 191 patients who underwent a PET CT. And the final pathological diagnosis was malignancy in around 75% of these patients. However, tuberculosis and benign lesions do make up a very large chunk of, diagnosis in our country. So all lung nodules that you encounter in India are not actually lung masses or lung malignancies. A lot of them would still turn out to be infections, tuberculosis, and a lot of other infections, including fungal infections, sclerosing hemangiomas, and various, other benign nodules. So you need to always, if you're getting a PET CT for a lung nodule in our country, that must not be taken as a, surrogate for malignancy. Any patient who has a PET avid lesion, high risk or otherwise, probably we need to screen these patients. We need to do a tissue diagnosis before proceeding any ahead. And this is again from the same study. And this also drives home a very important point, because a lot of us are, we are over dependent on the FDG values, the FDG uptake. And it is commonly thought that the higher the FDG uptake on a PET scan, the higher the chances of that lesion being a malignant lesion. And what this study also told us was that there was not much significant difference between the FDG uptake values between the malignant nodules and the tuberculous nodules. So in a high-risk country like India, in a country wherein the nodule can be anything, please do not rely only on the FDG SUV uptakes of the PET CTs, because this can also be misleading. And it has been shown that malignant, non-malignant lesions, including tuberculosis, can have similar SUV values. So the way forward is always to go ahead and do a tissue diagnosis before you can label these patients to be having lung cancer. This is, again, we do not have good data from India wherein, where trials such as the Nelson trial, the Dante trial, the larger trials which have been done in the West, we do not have similar kind of trials from our country wherein formal lung cancer screening has been done, but we do have data from China and we do have data from Brazil, where I feel the population would be somewhat similar to the Indian population. And this is the Chinese, the data on lung cancer screening. It was slightly different than the Nelson, because Chinese, the patients that they included were younger patients than Nelson, around 45 years. Obviously, the rest of the risk factors were similar. The patients had to be smokers. There were history of prior lung cancer in any of the family members or other cancers in the same patient. So the biggest advantage was that they were taking endemic risk factors. They were including patients who were younger in age, and they were also looking for people who were exposed to, cooking oil fumes, because this is thought to be a big risk factor in the Chinese population. So what they found out was that even in this, when you do it in a country wherein the lung nodules can be a lot of other things except, lung cancer. So in the Chinese data also, it was seen that the false positivity rate of lung cancer screening was extremely high. It was to the tune of around 1/4, around 21 to 25%. So in countries where infections and tuberculosis is endemic, screening sometimes would give you a lot of false positives. And if you look at the Chinese data, the ratio, the prevalence of false positives is much higher than what it was seen in the Nelson data from the West. So this is something that you need to keep in mind when you are screening patients in India. Who can benefit from screening in India? Well, the number of people who can benefit from screening in India are exceedingly high. Around 267 million Indians use tobacco. 17% of the Indian population is more than 60 years of age, and in this population, around 10% of them would be smokers. So the absolute numbers there are huge. 8% lung cancer patients in India give a history of having a first-degree relative who's had lung cancer ever. The healthcare industry can benefit a lot because, this would open up avenues for advanced IP, training of thoracic surgeons, doing more procedures. So if we take it in the right context, a lot of Indians would benefit from proper screening if it is done. And I think the way forward would be to set up local guidelines, local protocols. We need to see our population, our risk factors, and probably come up with trials and criteria with which we can screen our patients. We need better nuclear medicine and radiology services, proper CT scans, proper low-dose CTs or contrast-enhanced CTs when they're required. The qualities need to be standardized. We need more IP services and, places where even if you pick up a solitary pulmonary nodule, you can do something with them, you can sample them, you can biopsy them, you can offer them some kind of surgery. We need to make IP training more affordable, more approachable so that more people can do it. We need to train our thoracic surgeons because this is a big pain. Finding a thoracic surgeon in our country, for whatever reason it is, even if it is for decortication for a patient who has tuberculosis, leave alone, doing a lobectomy or doing a small pulmonary nodule is a difficult task. It is a challenge and we need to somehow overcome this. This is extremely important. This is something that is being done by a lot of people, and I think we need to now start doing this in India, biomarkers and breath markers for early diagnosis of lung cancer. Loads of data coming up on this, and I think in the next few years, in the years to come, this is something to be looked out for. And it would be great, if this comes into the clinical practice and we have some kind of biomarkers or breath markers in the times to come wherein we can pick up these patients early. And of course, we need to set up, because the biggest risk factor as of now, as we all know, is of course tobacco and smoking. Unfortunately, we do not still have formal tobacco cessation programs in our country. So I think when we talk about high-fangled screening or IP or PET CTs, I think the most basic thing that we can do is we can at least start with smoking cessation programs in our clinics and tell our patients to not smoke. Thank you so much.